Hi everyone, my name is Ben. I'm a third-year medical student and I am also a trans man, and I'm here to speak today about puberty blockers. And I'm going to take the next 4 to 5 videos to really talk about puberty blockers. So we're going to be talking about their mechanism of action, why we would even use puberty blockers in the first place, who should be getting them, who should not be getting them, what kind of side effects are they going to have, and are there any concerns that we should be worried about in giving people puberty blockers. And the reason why I'm taking so much time to go into this is because there's a lot in the media right now surrounding transgender healthcare and whether or not puberty blockers should be given to children who are trans. And this is something that is really, really important to me. Being a trans person myself and also being in the medical community, I see a lot of people who are speaking a lot about puberty blockers who have no idea, number one, how puberty works in the first place, and number two, have no idea about these medications that we are giving. And so I wanted to just take what I've learned from medical school and from the resources that I've been given through my training and just pass it along to you so that you can have a better understanding of how these work. And for my friends in medicine, if you are trying to figure out where you stand on this issue, I know a lot of my information is coming from primary care resources, and primary care doesn't seem to be this glamorous field to go into, but these puberty blockers are life-saving medications. Transition is not easy for anybody, and it is something that really could save somebody's life. So before you just toss it off saying it's too new, it's too controversial, I want you to think about the potential that you can have on a trans person's life in informing yourself about these medications and knowing how to administer them properly. So with that PSA out of the way for the medical community, today we're just going to talk about the mechanism of action of these puberty blockers, namely one class in particular, and we're just going to explain how puberty blockers work at all, because it's actually a really fascinating process. So there are a few different drugs that can be used, and I'm going to go over some that are all part of the same drug class, and I'll go into the drug class in a little bit because that will lead us into its mechanism of action. But the first drug, the most commonly used one, is called Leuprolide in its generic form, but it is also, its brand name is Lupron. Second one, generic, is called Gozrelin, and its brand name is Zoladex. And then this one I didn't even know about until I was looking into this, but this one is called Hystrelin. And from what I can tell, Hystrelin is something that's used more for people just starting transition, and eventually they would be moved from Hystrelin to Leuprolide or to Gozrelin. So this is just a temporary step in the very beginning, if it is used at all, but I figured it deserves an honorable mention. And this brand's name is Suprelin. And these all have similar mechanisms of action, but the main difference is in administration and how often you take it. So Leuprolide is given intramuscular injection, and this is done, Q just means every 4 weeks for Leuprolide. And then Gozrelin is given sub-Q, so underneath the skin, subcutaneous, and this one is also every 4 weeks. And then Hystrelin is an implant. It is a subcutaneous implant that is given every 12 months. But this is one, again, they're not going to be on long term. So I think after 2 years, they need to switch over to Leuprolide. Leuprolide is the most common one that I see used. But these are options. There are other options as well. But these are the main ones that we are going to be focusing on in my videos. Okay, so before we get too far into mechanism of action, I want to talk about some basic pharmacology, just so this process makes sense, because this is a very counterintuitive mechanism. But just some basic pharmacology, drugs have to interact with the body in order to work. If you just have a drug that doesn't interact with the body at all, it's not going to have any function. So I'm going to talk about two terms that are going to make this make sense. So we have, first term is agonism. And agonism is what happens when a drug enhances an effect in the body. So let's say, for example, we have a hormone A that is supposed to bind with receptor B. And we also have a drug C. Let's draw a couple more receptor Bs. But A can bind to B and cause a cascade of events to happen in a cell. Let's say C is an agonist. So an agonist is going to have the same effect as the original hormone A. So if C binds to receptor B, then it is also going to have the same end result. And so if you have a certain amount of A that is binding to receptor, and you also have C that does the same thing when binding to a receptor, you get an increased response. And so that is agonism. So this drug C is helping out hormone A in accomplishing whatever it's supposed to accomplish. So if hormone A is supposed to increase your blood pressure, then adding C would also cause an increase in blood pressure because they are agonists. And then the other one, its opposite, is antagonist. And an antagonist opposes. And so let's say, again, here we have hormone A that's supposed to bind to receptor B, but this time I add drug D, and drug D is an antagonist. So drug D is not going to allow A to work. So if D binds instead of A, then you're not going to get the response from A, and so that is an antagonist. Okay, so I've pulled up our drawing that we did in the previous videos about the HPG axis. As you can see, this is the simplified diagram that I drew in that video. But the mechanism of action for all of these drugs, these are all in a class of GnRH agonists. And this is really seemingly counterintuitive because I know what you're saying. Ben, how in the world would a GnRH agonist be able to block puberty if GnRH, let's review this pathway, if GnRH stimulates release of LH and FSH, and that causes more estrogen, more progesterone, more testosterone, then how could increasing GnRH block puberty? And that is a really great question. We're going to get into that. But this is why it is so important to understand that this is an agonist. But you should also remember our pathway from last time, and we'll go over it again. So if we remember, our hypothalamus produces GnRH. GnRH is going to go to the ant pit, so on and so forth. But this time, we're going to add leuprolide. And so if we add, that is not green. If we add our leuprolide in green here, this is going to show us that we have stimulation. We are going to get increased GnRH. And then what's going to happen with increased GnRH? Well, that is going to signal to the anterior pituitary. We are going to increase LH, and we are going to increase FSH. And then, so what's going to happen? Down here, we're going to increase these. So we're going to have high estrogen, high progesterone. We're going to have high testosterone from the testes. But remember that we have negative feedback that is happening here. So the more of these hormones that we have produced, the more inhibition we have on the hypothalamus. So remember, we have our block here at the hypothalamus and also at the anterior pituitary. Same thing here with testosterone. We have our block and our block here. So yes, we are going to increase GnRH, but that cascade of increasing all of these hormones down the line is going to cause a massive negative feedback to go back to the hypothalamus and the anterior pituitary and cause these to now go down. And this is how we block puberty. And this is also where we get a lot of our side effects. Because you may have heard there are lots of known side effects, especially when just starting a puberty blocker. And that is because in the beginning phases of starting this medication, you are increasing GnRH. And in increasing that, you're increasing estrogen and testosterone. So yes, in the first bit, you might have extra dysphoria. You might have some hyperaggression, emotional states. You might have a lot of things to work with in the first bit while these hormones are increasing. But at the end of it, you're going to get inhibition of the entire pathway. And so that's how you can completely shut it down. So a really important thing to note here is that these drugs are not only used in treating trans kids. They actually are used in treating endometriosis, in treating prostate cancer, in treating precocious puberty, which is puberty under the age of 8. And the way that those drugs work in those situations follows a similar mechanism. However, if you were to give any of these drugs in a pulsatile fashion, so when your body is making these hormones, it's going to produce GnRH in a pulsatile fashion. So it's not continuously releasing GnRH, and that's why your body isn't constantly inhibiting this pathway. Because if you just release a little bit of GnRH at a time, you'll just get the stimulation and you won't get the inhibition every single time. However, this drug mechanism is done by agonizing, so enhancing GnRH continuously. And since you're doing it continuously, you are relying on this increase at the bottom of this pathway, because we are going to have, it's going to back up down here because it has nowhere to go, and it's just going to start inhibiting back up here. So it's important to note that it is a continuous agonism of GnRH and not pulsatile, because pulsatile is not going to block puberty, whereas continuous is. And so this was a lot of information to work with for one video, and I hope it was as exciting for you all as it was for me to learn about this stuff. And if you have any questions or comments, leave them below. Also, please like this video, subscribe to my channel, and then also I will be getting out more videos on this. So please stay tuned, watch the rest of this series as well, and I will catch you all in the next one.